I'm here with some incredible supporters of our foundation, and we are so appreciative. Dr. Amanda Adeleye is the founding partner and medical director of CCRM Chicago. Thank you so much, Dr. Adeleye, for being here, and Dr. Segal Klipstein, who has been a supporter of the foundation since the beginning, is the medical director of InVia Fertility. So thank you for taking your time. Zameena, thank you. Zameena Lakhani is our genetic counselor from Northwestern, who kindly is coming here as well. So we are so appreciative to everyone for being here, and we appreciate Ferring Pharmaceuticals, who sponsors us and these webinar series, because one of our missions as part of the foundation is educational mission. And so we do quarterly webinars free of charge, thanks to Ferring. Again, exactly as Taryn had said, we are going to really dive into a question format for each of our panelists. And then if you, as a listener, has questions, please submit that to the Q&A functionality, and we will answer them at the end. As a reminder, this will be posted to YouTube and all our social media channels. For those of you that don't know, the Chicago Coalition for Family Building, or CCFB, as we kindly think of it, believes that building a family should be a human right, not a privilege. So our mission is to remove financial barriers that prevent creation of family through our grants. So we help really to meet that divide that occurs between those who are covered with insurance and those who remain under or uninsured. In fact, thanks to our incredible partnerships with both JUF, Metropolitan Chicago, Pats and Parenthood, we are opening an additional round November 15th. Our annual round typically is during Infertility Awareness Week in April. So our details can be found on the slide. November 15th, you can apply for $10,000 to assist in fertility treatments such as IVF, IUI, donor egg, donor sperm, gestational carrier, genetic testing, frozen embryo transfer, legal fees, all of the pieces, adoption as well. So please look at that if that applies. On the 15th through the end of the year, you can visit our website and apply online. And we also appreciate you to spread the word to those who may benefit. So a bit more about our incredible panelists. Dr. Adeleye completed her medical education and residency at Columbia, followed by an REI fellowship at UCSF. As a fellow of the American College of OB/GYN, she's committed to advancing the field through both practice and research. Dr. Adeleye is the founding partner and medical director of CCRM Fertility in Chicago, which will be opening in 2025. Dr. Klipstein is a graduate of U of C, Pittsburgh School of Medicine. She's board certified in both OB/GYN as well as reproductive endocrinology and fertility. She completed her fellowship in reproductive endocrinology and fertility at Boston IVF and Harvard, as well as a fellowship in medical ethics at Harvard. She's the medical director of InVia Fertility. Zameena Lakhani is a preconception genetic counselor at Northwestern Medical Center for Fertility and Reproductive Medicine, and she's also instructor of OB/GYN in Division of Clinical Genetics. She earned her master's degree in genetic counseling from Northwestern in 2021, and she joined that team at Northwestern shortly thereafter, focused on infertility, recurrent loss, and preconception risk for genetic disorders. So thank you all. Thank you for being here. The focus of our talk today is to really help with what a lot of people think about as like alphabet soup. So there's PGT-A, there's PGT-M, there's all these letters. And so hoping that someone might walk us through what is PGT-M and how does it differ from PGT-A? Amanda, do you mind taking that one?
Yes. Okay. So PGT stands for pre-implantation genetic testing. So that is where an embryo that's made in the IVF lab is tested for some genetic question. So the most typical would be PGT-A, where the A stands for aneuploidy. That means having a different number of chromosomes than what is typical. So typically we all have 46 chromosomes, including an X and possibly a Y, depends. And so aneuploidy looks to see, does the embryo typically have the right number of chromosomes? Whereas PGT-M means that the M is for monogenic condition, so like a single gene disorder or difference. And so it's a different way of testing the DNA to see, does that embryo carry a genetic difference that might, result in a disease or a condition at some point in the future.
So who would you define, Dr. Adeleye, as an ideal candidate for PGT-M?
So folks that I would typically recommend to have PGT-M are going to be people that are carriers for a genetic condition, who they also have a partner or donor, if they're using a sperm donor or egg donor, that are a carrier for the same genetic condition. So what does a carrier mean? So we have, I think, like 5 million base pairs of DNA, millions and millions and millions of little pieces of molecules that make up our DNA, and we're all different. And some of those differences have no effect at all, but sometimes we can have a difference in a gene, a group of those little base pairs that can, potentially lead to a negative condition. So if you have that gene difference and your partner has that gene difference, then your offspring might be affected with that disease. As an example, sickle cell disease. If you're a carrier for sickle cell trait and your partner is too, then there's a chance your child could be affected with sickle cell trait, even if you two are not affected. So that would be testing for an autosomal recessive condition. Another reason might be if you have an autosomal dominant condition, that means you might actually already have the condition yourself. An example might be being a carrier for a cancer gene like BRCA1 or 2. People that have that genetic difference are at a higher risk for breast, chest, ovarian, and sometimes prostate cancer if you're somebody that has testes. So you might choose, like you might be doing things to protect yourself from getting a cancer, but you might not want your offspring to. And so you might still choose to do pre-implantation genetic testing for this monogenic condition, even though you're an adult and you're living and you're surviving with it. So people that want to avoid specific genetic conditions that they know about, that they're at risk of passing on to their children, are great candidates for PGT-M.
And so it's end of year, so we all know there's like crunch time with insurance. And so a lot of questions that patients see us is schedule. And so Dr. Klipstein, do you mind just giving a guidance for a patient of what the process looks like? Let's say they both did that genetic carrier testing. They identified that they both carry a mutation for autosomal recessive illness, and now they're seeing you and they're interested in PGT-M.
Sure. So I always caution patients that they need a lot of patience for this process because it takes time because there are several steps to the process. The first step is to identify that you're both at risk for having a child. So for example, if you're both the carrier of a autosomal recessive, as Dr. Adeleye had said, there's a 1 in 4 chance that you'd have a baby with the condition. And 1 in 4 embryos similarly would have a risk. So in order to be able to test embryos, you need to create these specific probes, and there are special companies, several of them across the country, that create these probes specific to your particular mutation that can cause the disorder or the condition. And it takes time. So oftentimes you'll need either a blood or a saliva sample from both of the intended parents, or if it's a donor, from the donor. Oftentimes they'll ask for, the companies that do the genetic testing will ask for samples from relatives. It could be parents, siblings, other children that might or might not be affected. And so that part takes a little time. And then creating the probe can take 6 to 12 weeks, depending on the complexity of the condition. So that's the first thing you do. Once the test, your specific test is available, then the patient starts the IVF cycle. And the IVF stimulation usually takes between 1 and 1.5 cycles. So sometimes there's a preparation cycle, takes about a month. And then in the second month, you take about 10 days of injections, little tiny under the skin injections, to stimulate the ovaries to make multiple eggs. Because with the IVF, you really want as many eggs as possible without overstimulating the ovaries in order to have the best chance that some of them will be unaffected by the condition that you're testing for. Once you do the 10 or so days of stimulation, you take a final injection to trigger ovulation. 36 hours after that, the eggs come out under a little minor surgical procedure with IV sedation. Those eggs then get mixed with sperm, are grown for 5 or 6 days. And then at that time, each of those embryos has about 100 cells. And so the laboratory technicians will biopsy about 5 or so cells from each embryo. The embryo always stays in the IVF lab, but the cells get sent off to the testing lab. And then it takes about 10 to 14 days for that testing to come back. Once that testing is back, you need to prepare the lining of the uterus to do the transfer. That takes a few weeks. So typically it's maybe 2 months to do the probe creation, 2 months to do the IVF cycle, and a month to do the transfer. So like the quickest it could be done is 3 or 4 months. Typically it's really more of like a 5 to 6 month process to get the embryos and then transfer them and have until you get to the pregnancy test.
What would you say to a patient that was concerned that by doing the biopsy for PGT-M, that you're impacting the health of the embryo? what are the potential risks of the biopsy itself?
So there are always theoretical risks. They're very small. Certainly, if you don't do the biopsy, you won't have the answer. So you always have to balance that. There's a small risk of damage to the embryo, but this is really very rare, much less than 1%. I mean, I guess there's a small chance that the DNA that you extract or the cells that you extract will be lost. Again, very, very unlikely. And there's a chance that you need to freeze the embryo and then thaw it out later. There's a small chance that the embryo won't thaw. But again, these are much less than 1%, very low risks. We haven't seen any risk to the babies who are born after these biopsies, and it's considered quite safe.
Thank you. Zameena, I'm sure you see many patients who are going through this process. How would you view your role as the genetic counselor and the guide for patients as they're starting this process, let's say, beginning to learn about how to make a probe?
Yeah, it's a great question. I think it depends a lot on if you're working with a genetic counselor that's housed in your fertility clinic, or if you're working with a genetic counselor who might be housed in the lab, or sometimes patients work with both. So I am based out of a clinic, and so my role is really to meet with these patients after they meet with their REI and talk to them about what are the different companies out there, what would be necessary in order to build a probe for them if one is possible, and kind of walk them through the timeline that was just described. What is this going to look like for you specifically? And then we can work together with the lab genetic counselor to really make that process happen. Once we have results, I can walk them through the results and work really closely with the rest of their care team to help them determine next steps. What do we want to do based on these results? Are we ready for a transfer? Is there something else we want to consider? Whereas a lab genetic counselor will still be able to go through your results, but may not be able to help you with any recommendations that might be based on any clinical policies or anything like that. So those roles will differ a little bit, and it might be a helpful question to ask your fertility team what type of genetic counselor you might be working with.
And can I ask, in your experience, how often is it that a patient initiates the process to create a probe, but they're unable to with PGT-M?
I think generally it's pretty rare. We're thinking about these in situations where a particular genetic change that they might carry in their family is much more complex, and maybe we can't get enough family members, or it's not in a range that's detectable. Most often this comes up if a condition is brand new in an individual, either the patient in front of us or their child that they already have who might be affected. So it's rare, but it can happen.
Wonderful, thank you. When you're counseling patients, how would you describe to them limitations of PGT-M in terms of its accuracy?
Mm-hmm. Yeah, so I think one misconception that patients have is that if they do PGT-M, that will eliminate the risk for whatever condition they're testing for, and that is not the case. PGT-M is what we consider a screening test. So it's telling us this embryo is high risk or low risk to have whichever condition we're testing for. Most labs can associate a specific accuracy with that. So there is a chance for a false positive or false negative result, and we can think about testing during a pregnancy to really further assess what's going on in terms of that specific embryo that was transferred. Additionally, like I just mentioned, it's not available in all cases, and so really making sure that you are plugged into a lab that understands your case and has all of the records that are needed, either through your clinic's team or your genetic counselor, will be really important to make sure that you actually can go through this process. I think every lab is a little bit different with what they're able to offer. And so really making sure that if something is not possible, understanding why it's not possible, so we can see, is this a limitation we can address, or is this truly just a complexity of the case and a limitation of overall what we have available today.
Thank you. Dr. Klipstein, how would you describe some of the ethical considerations you see in patients considering PGT-M, particularly if it's, exactly as Dr. Adeleye had said, for an autosomal dominant disorder, potentially something they themselves have?
Right. So I think there are a couple questions, right? So when we initially started to do PGT-M, we did it for things that were lethal in childhood. So things like Tay-Sachs or other conditions. And then it spread into things that were not lethal in childhood, but maybe lethal in later adulthood, like cystic fibrosis. And then we were able to test for things that were like early onset Alzheimer's, things like that. And then we were able to test for things that are not diseases per se, but are disease risks. So you can test for like your, if you're have a family history of breast cancer and you happen to carry the BRCA gene, for example, it's a common one we test for, you know that you're at increased risk of a variety of cancers, breast, ovarian, and so on. But it doesn't mean you'll get the disease. So the question then is, should you test for the disease and exclude it? So on the one hand, if you have a strong family history of cancer, and you don't want that anxiety for your children, I think it's a great idea. On the other hand, you could argue that you're using resources from society for something that isn't childhood onset, and that really, in the end, you can't test for everything. You can only test for a couple of things. And you know, I think the other thing is that sometimes people come to us and they say, well, you know, I'm going to do this genetic testing, and so I'm going to have a perfect baby, right? And I think that it's really important for us as providers and counselors for our patients to explain that, you know, we can test for certain things with pretty good accuracy, not 100%, but very good accuracy. But that we can't test for everything, and you can't guarantee that everything's going to be perfect on the other end. I think the other ethical issue that comes up is that sometimes we have patients that come to us because they want to avoid a certain condition or disorder, and they come and they do genetic testing and they say, great, I'll just test my embryos, I'll find the normal embryo, I'll have a baby and all will be well. But then what may happen is that they've done a number of cycles, they've either exhausted their benefits or they've made as many embryos as they can possibly make, run out of resources, and now they've transferred the embryos that were unaffected, and that those embryos didn't result in pregnancy, and then they're sort of left with a situation where they have to decide what to do with the remaining embryos that are all affected by the disease. So for example, if you come in to avoid an autosomal recessive disease, the chance is 1 in 4 that you'd have a baby with that disease. But the chance is 1 in 1 is 100% if you know that you're transferring an affected embryo. And so that becomes an issue. And in some cases, the decision becomes, you know, not having a baby or having a baby with the disorder that you actually came to avoid. Where, you know, if you tried on your own in the bedroom, you know, for heterosexual couples, at least the chance of having an unaffected baby would be, you know, 75%. So I think those are ethical issues that we deal with all the time.
Thank you. Yes. Dr. Adeleye, a lot of times patients will pursue both PGT-A and PGT-M. In your experience, is that something you see commonly? How do you guide patients to get a sense of, this is always really hard, depends on the PGT-M illness, but how many embryos they may need to screen, things of that nature?
Yes, this is something I definitely spend a lot of extra time counseling patients about. So typically in my experience, when my patients are doing PGT-M, it's usually with a company that will also do PGT-A at the same time. So I haven't had a patient come through that's only done PGT-M, although that is possible. And so what winds up happening is you have these competing interests of trying to get a euploid or chromosomally normal embryo, and then also one that is unaffected. And sometimes, as Dr. Klipstein had, you know, described, unaffected might be, you know, 3 out of 4 embryos, you know, 75% are normal, or it might be half. And so I've definitely had situations that are frustrating where patients might be making euploid embryos, but those embryos all happen to be affected with the condition. And so there is this extra layer of counseling around, even for my best prognosis candidates, like my patients that tend to be, you know, under 35 with no other underlying conditions, they may still wind up needing more IVF than another person, you know, in a comparable scenario, because we're looking for unaffected and euploid embryos. So just to be prepared.
We are discussing a lot about PGT-M and PGT-A. Our field always is advancing, sometimes, record pace. And so I don't know if everybody would kind of share, what do you sort of see as the next level of PGT testing, the next phase of genetic testing in the context of reproductive medicine? And what are your sort of initial thoughts? I don't know if, Zameena, if you don't mind, if you want to start, or.
Sure. Well, I think that PGT-M and A are currently alongside some other, I like the alphabet soup thought, that there's some other letters in there that are currently used kind of clinically and pretty commonly. So SR would be one of them for structural rearrangements, and HLA for matching are commonly used. I think there is some preliminary work around thinking about PGT for polygenic diseases, so things like diabetes, for example, that are not monogenic, they're not caused by one specific gene, but different genes can play a role. It's not the whole piece of the puzzle, but it's one piece of risk. I think there's also some companies that are starting to develop tests that are more kind of whole genome or whole exome for embryos. My personal opinion on that is I don't know that we have the data yet to support this being used for everyone. And I think we have a lot of interesting research that we could and should be doing to really understand how helpful that can be in a clinical setting. We're not there yet, but it'll be really exciting to see what's to come in the future.
Absolutely. Yes. Dr. Adeleye, what would be your thoughts about sort of PGT in the context of more polygenic disorders?
Yeah, quite frankly, I'm really curious to know what Dr. Klipstein thinks as the, ethicist in the group, because my concerns are really around the ethics of all of this. I think, on the surface, it might seem like, well, great, if we can choose, to have an embryo that has the highest IQ possible, why wouldn't we do that? And I want to pause to explain to the audience that in these polygenic tests, there are some folks out there that are looking to see if they can assess embryos for characteristics like intelligence or other just more aesthetic appearances that have a really more like a social value and not like a medical value. And I think there's some degree that that's possible, in the next, I don't know, 10, 15 years, but people are working on this. So that is, I think, the next frontier, but I think that it's ethically complex. And I think we start to get into this murky area of what is what's medical versus, sort of like what's social. Like as an example, right, there's a gene that, or a set of genes that, help give me the color of my skin, right? You could look at it from the outside and say, well, Black people have twice the rate of maternal mortality than white people, and Black people have X, Y, and Z. So maybe it's good if we just like choose embryos that don't have, that set of genes. Well, I'm also very proud of my heritage and proud of like what it means to be a Black woman in America. And I want to give that to my kids, right? So if we, and it sounds extreme, but I think the technology could be there at some point in the future to choose things that are really not medical. And what does that mean for all of us as a community, both, of people that have fertility challenges and then also globally? So I think, the future is coming and we need to be having these serious ethical conversations now. But again, I would be very curious about what Dr. Klipstein has to say as a real expert in ethics in our field.
So, okay, so I think that, yes, I have a lot to say on the ethics, but I think if we step back and just look at the pragmatic side of it, we all carry risks for things, right? We all have a risk for heart disease or diabetes or elevated cholesterol or cancer or schizophrenia or, any number of things. And when you start testing for embryos for multiple things, especially diseases that are polygenic and then don't express themselves until later in life, you're not going to have a perfect embryo, right? And so then how do you choose, do I take the embryo that has the increased risk of breast cancer, but the lower risk of heart disease, or the increased risk of schizophrenia, but the lower risk of, I don't know, dementia, Alzheimer's? I think that that's sort of an impossible thing. And so the companies that do this polygenic testing say that they're really not screening embryos, for transfer or not, but they're ranking them. And that's fine, but I think ranking has everything to do with sort of how you value certain things and how afraid you are of certain diseases. That's one thing. The other question is, what is a disease, right? And so I think that this sort of concept of health versus disease, there is no perfect health. And the only way that we actually describe health, if you look at all the definitions, is the absence of disease, which means that we don't really have a definition of what is health. And also, I think that there's a lot of sort of discrimination in testing for even simple polygenic disorders because, are we saying that people who have certain disorders are less valuable to society and we should screen them out? And if you take out, these technologies are only going to be offered to people who have the means to pay for them. So now people who are of higher means are now not going to have heart disease. So maybe there's going to be less research in heart disease, and people who could really stand to benefit are not benefiting. So those are all kinds of the things. I think the other issue is that this testing is not really ready for prime time. The the data sets that have been used to do this research have all been kind of Eastern European, Caucasian data sets, so they don't really apply broadly. That's one thing. The other thing is that you don't know that a disease that you test for today, you don't know if your testing is correct or not, and you're not going to find out for 50 years. So that, those parents are probably going to be long gone. Hopefully not, but maybe. Those children, are going to be growing up in a very different world. And I would really venture to say that these diseases that are decades in the future are not going to look the same then as they do today. And certainly you can look at a lot of the diseases, the common diseases that ail us, the treatments are so much more advanced and people are surviving them, and our health is improving, and well, until COVID, but anyways, in general, our health is improving as a society. And so you don't really know how those are going to be expressed. The other, like I said, I could talk forever, but the other thing is that when you exclude one disease or one set of diseases, you might be excluding things that are good. So there's this concept called pleiotropy, where diseases tend, or disorders or conditions tend to travel together. So what if you're excluding, an example of that is schizophrenia. No, I think it's bipolar disorder. Actually, Zameena can correct me, is associated also with increased intelligence. And so you might be, decreasing one thing, increasing another. And so you don't know that by taking something out of the gene pool, you might be taking out a bad thing, but also a good thing. So there are a lot of things to think about. I would say that there are a few companies that are offering this commercially. I don't think it's really ready for prime time. The research certainly hasn't been done. And I think that there's sort of like lower hanging fruit. I mean, I think if you, improve sanitation and education and, decrease smoking and work on obesity, you're going to get much more health than by like looking at these polygenic conditions. The other thing is that, without being able to repair the genes, it's not that helpful, because within a given family, if you have a risk of, I don't know, lung cancer, yes, you can decrease your risk in many ways, but like all your kids are going to have, or like maybe diabetes is a better example. If you have a risk of diabetes, if you have diabetes, your kids are going to have an increased risk of diabetes, much more so than a family that doesn't have diabetes. So all your embryos are going to be at increased risk. It's just a matter of how much increased risk. So I think that there's really minimal benefit to these types of technologies. I think they have to be sort of taken at face value. So I would say that this is not, where we should focus our energies. There's so much more to do, and so many better ways to use the resources that we have.
And Dr. Klipstein also reminded me one other issue is environment too, right? Like, so a lot of these conditions are going to be in the context of the environment in which you're raised, and that can like raise or lower your risk. And so I think it's also concerning if patients are thinking that I'm going to have a child that's going to have this IQ and, no heart disease, et cetera. But if you raise them in a very stressful environment, or, a carbohydrate rich environment, you might still wind up seeing some of these conditions that you're trying to avoid.
Yeah, thank you all. That was incredibly interesting and informative, and just even the practical pieces. We all know just from doing PGT-M and A, you have to screen a lot of embryos in many cases just to find one that's eligible. And so you could be tasked with that as well. We'd be doing more cycles. And we're here focused as an entity, as a foundation, about just access. So I think it's really wonderful to hear about what's currently being utilized and what's theoretical for the future. And I can't thank you all enough for being here and being a part of this. There's always obviously so much more to discuss, but we want to give an opportunity for those of you who are listening, if you have questions, so that we can answer those. Look. So here's a question. We have an aneuploid embryo. It was an embryo with a euploid, and we now have one child. So my sense is there were maybe two embryos. One was euploid and created a child, and one that remains is aneuploid. There are studies papers that an aneuploid embryo can correct in the womb. What are your thoughts? Would you retest? Would it be possible to still do a transfer? But this is a great one. Zameena, I don't know if you want to talk about the concept of aneuploidy and theoretical self-correction.
Sure. Yeah. It's a good question. And I think sometimes it's interesting to think about. I have a lot of patients ask this question, like, well, they came in the same cycle, so could there be a connection there? And generally the answer is no, that your embryos are each completely separate entities, and the results of one would not impact the results of the other. I think this idea of self-correction is it actually in practice is much more complex than it sounds. That's not quite the way that it works out, that we have self-correction. And I think there's a lot of evidence that aneuploidy really started when the embryo was created. So it's something that typically persists throughout all of the cells. Versus something like mosaicism, which some attendees might have had results that came back like mosaic, where we have some cells that are thought to be euploid and other cells that are thought to be aneuploid. At this point, and anyone else feel free to jump in, but I'm not aware of any data that suggests that retesting the embryo would be helpful, because we would expect to get the same result. So I don't know that is going to help get a different answer. And I don't think that that concept of self-correction in the theory that we're thinking about it really would apply to an aneuploid embryo. And maybe we could dive into that a little more.
Yeah,
I think that's great, Zameena, and I would echo that. So for the folks in the audience, nowadays, when genetic testing does happen on embryos, you take a few cells from the embryo, then you isolate the DNA, and then that DNA is all diced up and then laid around a, we call it like a kind of primers, like other DNA that kind of has like a standard order to it. And what happens is that data, how sticky essentially is that DNA gets passed through these algorithms, through these computers to determine does the embryo have the right proportion of chromosomes. And so when an embryo is euploid, it means yes, like all of the proportions are correct. When an embryo is mosaic, that can mean many different things. Sometimes the embryo has just maybe one embryo and a few cells that maybe it's a little off, so the signal's a little different. And some, it can be most cells are abnormal, but not all of them. An aneuploid embryo means that the signal that's been detected is that of all of the cells you sampled, they're all abnormal. So the likelihood that an aneuploid embryo that gets read as aneuploid is actually euploid is very low. Typically, there's more of the conversation happens around mosaic and like low mosaic embryos, and are they the ones that are correcting in utero? And that's, as Zameena said, like it's very hard to measure, but it's potentially possible. But aneuploid embryos are probably not going to self-correct in utero.
Yeah, I think the question of retest, exactly like Zameena said, the challenge is then which test do you believe? Exactly as Dr. Adeleye had said, mosaic, I always think of it like mosaic tile in your bathroom. There's two types of tiles, there's normal and there's abnormal. But it's just one tile in the bathroom, it's much more clear that that's the issue. And so I think the challenge is we do these tests because we want to use this exactly as a screening tool, which to transfer theoretically, which not to. The question was, would it be possible to still transfer? I am unaware of a clinic that transfers aneuploid embryos, but it sounds like Dr. Adeleye I should say in a cycle where the goal is to create pregnancy. Oh, did you have a thought, Dr. Adeleye? Oh, no, sorry. So my mistake. Theoretically, there could be. We just learned also that this was part of our donor egg cycle and that a surrogate was utilized. I would say that there are other complexities now about a surrogate who would theoretically be comfortable with transferring an aneuploid embryo given the likely outcome, depending on the chromosome that's aneuploid, of either miscarriage or pregnancy with challenges. So I think that I would definitely review with your clinical team, but the standard would not be to rebiopsy and the standard would not be to transfer that embryo. I don't know if there are other questions. Someone asked if the tests are 100% accurate, and the answer to that is no. And I think we kind of have reviewed about that. Unfortunately, nothing is 100% in medical testing, including these. And so depending on the genetic company and the assay that you use, people will quote like sensitivity, likely if it was positive, it's really positive, 95 to 97% or so, but nothing is 100%. I think that's key. That's exactly what Dr. Klipstein had said, is that we cannot guarantee that this is the embryo exactly of someone's, of that potential plan of desire. So no, the answer to that is no, the testing is not 100%. I think that might be the end of our questions. So I am going to just thank again, everyone for being here and our amazing panel. This was such a huge gift. You guys took time. You live very, very busy lives and clinically very busy. So I can't thank you enough for everything you do to support the foundation, including your presence today. This is just a plug for anyone listening. We appreciate any and all support to the coalition. So volunteer, or financial, or any piece, or just to follow us so that we can help you or friends who may be utilizing our services, whether it's education or grants to create a family. So if anybody else would like to share some closing thoughts, or Taryn, if there's anything that I missed that you wanted to add.
No, thank you all for your time. And as Dr. Hirshfeld-Cytron said, if anyone has closing thoughts, please chime in. Otherwise, thank you all so much for being here today.
Thank you.
Yes, thank you. Thank you again.
Thank
Well.
you.
Thank
you.
you.